As Dr. Raghu says, ARDS is more important than food. I find it difficult to believe, but he's our leader. We have to follow his lead. So yesterday, when I was here listening to all these talks and people describing fairly complex concept in such simple terms that I could understand, I realized that the talk I had prepared would not work. So Dr. Raghu's talk has set this up very nicely. So I'm going to stick to very, very broad concepts that are achieved with the tools that were presented yesterday, and we will continue to do in our practicums, including ECMO. So we start with the most basic concept of all. So unless we breathe or are breathed for, that is ventilated, it's very simple. We die. So it's a good idea to keep on breathing, or if you cannot breathe on your own, then let somebody else breathe for you and be ventilated. And that essentially is what we do in ARDS. This has been covered a little bit, but I'll just say that, as you all know, in 1967, ARDS was described on 12 ICU patients who had this very severe hypoxia, which was not responsive to any therapy. And this gentleman, he actually did suggest that PEEP could be one of the treatments, and that's where it started. Over the 70s to 2010s, multiple definitions and criteria have been proposed, but the currently most acceptable one is what was proposed by the ARDS task force, the joint task force with the Americans and the Europeans, and that's called the Berlin definition. There's not exactly a definition, it's more of a criteria, which I'll go to in a minute, but the best definition I found was, and each word here is important, that ARDS is a diffuse inflammatory lung condition. It has an acute onset and is characterized by increasing closing volume, that's why the alveoli collapse, reduced lung compliance, and pulmonary hypertension leading to severe hypoxia. So as I said, every word is important. It's a diffuse process. It's not a localized process of part of the lung. It involves entire lung and bilaterally. It is an inflammatory lung condition. It may be, the etiology may be from lots of places, but it's an intrinsic lung condition, not explained by cardiogenic edema or something like that. It characterized by, as I mentioned, closing volume, reduced lung compliance, and pulmonary hypertension, and leads to severe hypoxia. That very often is resistant to the common modes of treatment. It is widely accepted, though more and more modifications are being proposed, can we include non-invasive ventilation, like high frequency, not high frequency, but high flow by nasal cannula to be part of it, because one of the criteria does not include that. So as I said, the Berlin definition is more of a criteria, 5 of them. Onset is acute within 7 days of the enticing event. It's diffuse, bilateral opacities on imaging, either a chest radiograph or CT. The origin, it's intrinsic to lung, not cardiogenic or from other sources. The edema is intrinsic to the lung, or the inflammation is intrinsic to the lung. Then oxygenation is an issue defined by PF ratios. To call ARDS, you have to have a PF ratio of less than 300. So let me ask you something. Somebody has a PaO2 of 300 and a FiO2 of 50%. So is that person's PF ratio 6? Huh? Right. So we all do this. Say FiO2 of 50%. F stands for fraction. And all my medical students and residents know that I'm very particular about that. So you cannot say FiO2 of 50. You should be saying 50% inspired oxygen or FiO2 of 0.5. And these type of formulae sometimes, makes you think, my formula is correct, but if you don't understand the basic concept. So in 2004, NASA launched a Mars probe, cost us $250 million. Every system on that probe worked well, and yet the probe crashed on Mars. Anybody know what happened?
Metric scale versus...
Yeah. That's right. Half of NASA was working with the metric scale, and half of NASA was working with the foot-pound and second scale. So these terms, while sometimes we find them silly, but there's a reason why things are called what they are called, and it's good to, in my mind at least, stick to it. Anyway, the second element of that says that oxygenation is on the lower side defined by PF ratios, despite using at least a PEEP or CPAP of 5. So without a CPAP of 5, the definition does not stand. Sorry. Then the severity is defined by the PF ratio. Mild is 300 to 200, moderate 200 to 100, and severe is less than 100 millimeters of mercury PF ratios. The causes of ARDS, I'm sure all of you know, are myriad. I won't go into them. Dr. Raghu presented some of them: sepsis, shock, severe lung infections, aspiration, major trauma, lung contusion, inhalation of toxins, pancreatitis, transfusion-related lung injury, drowning, drug overdose, and ventilator, call it physician or healthcare, induced lung injury, called villi, and then thoracic surgery, especially people on cardiopulmonary bypass. What is the magnitude of the problem? Again, something Dr. Raghu touched on. 10% of ICU admissions and 23% of patients on ventilator have ARDS, at least the mild form. Mortality is significant in the younger age. It can about 24%, and in older ages it can go as high as 60%. So it is a bad problem. And as was presented, if you treat it well, the long-term effects are persistent, but the people can lead a reasonably normal life. So there is a return on investment if you treat these people. A little bit of physiology. So there is the air passage, the alveolus lined by the type 1 and type 2 pneumocytes, and the capillary lined by the endothelium. And then the most important part of the lung is this respiratory membrane, which is the type 1 cell on the alveolar side, type 1 pneumocyte, a shared basement membrane with the capillary endothelium and the capillary endothelial cell. And the normal thickness is about 1 to 1.5 micron. And how does it work? Oxygen-rich air comes into the alveolus. It diffuses into the plasma, and there it is absorbed by the hemoglobin in the RBC by that famous curve. And we know why it's sigmoid shape, because as more and more oxygen gets onto the hemoglobin molecule changes from the tight to the relaxed state, making it easier for the subsequent oxygen molecules to add on, and that's what gives this classical sigmoid curve. And then CO2 is primarily, unlike oxygen, which is primarily distributed through the RBCs and hemoglobin, CO2 is primarily transported, dissolved in the blood, and that just has a straight diffusion path into the alveolus, and by expiration, the CO2 is exhaled. Well, what happens in ARDS? The type 1 cell is destroyed. That is the primary problem, that the type 1 pneumocyte is destroyed. That reduces surfactant, leading to alveolar collapse. The alveolus gets filled of inflammatory exudates, reducing alveolar ventilation. And the respiratory membrane, this beautiful 1 micron thick organ, really gets affected because it is inflamed. That directly leads to reduced diffusion of oxygen. That becomes a central problem of, even if you have a lot of oxygen in the alveolus, it does not get into the blood. So type 1 pneumocyte damage leads to surfactant loss, leads to decreased compliance, increasing closing volume and alveolar collapse. Inflamed respiratory membrane develops a diffusion barrier, which leads to a VQ mismatch and increased intrapulmonary shunt. And then tachycardia. When an RBC traverses the alveolus, it gets fully oxygenated in the normal state within the first third of its traverse time. But because of the diffusion barrier, there's not enough oxygen reaching the plasma, so it takes much longer. Having said that, there have been trials using reducing heart rate, and they have not shown of benefit with the reducing heart rate to increase dwell time, but they did not show any benefits. So as Dr. Raghu said, the prevention is much more important than, and all of these causes can have preventative strategies: sepsis, shock, early detection, source control, normalization of perfusion, severe lung infection, early detection, first prevent the lung infection, or if it happens, early detection, prompt treatment, aspiration prevention, major trauma, wear your seatbelt, inhalation of toxins, pancreatitis, transfusion-related, minimize transfusions, drowning, avoid dangers, and learn how to swim. Drug overdose, minimize, healthcare-related lung injury, lung protective strategies in every place. Don't use too high tidal volumes because they will, today the patient is fine, tomorrow the patient will suffer. Of course, my shift will be over, Dr. Raghu can take over and then he can do whatever he wants, right? I can make the patient sick. Surgery, less invasive and minimize cardiopulmonary bypass. So now I come to the meat of the things, why we're here. So all that was nice and dandy, but if it does happen, what do you do about it? So that's secondary prevention. So first of all, treat, manage, or eliminate the inciting event. Then ARDS management treatment. First of all, we have to understand there is no cure. It was nicely presented. There have been multiple interventions tried that actually can alter the course of the disease. There is no cure. So we should approach it with a dose of humility that all we can do is support, treat hypoxia and allow the lung or the body to heal. There was this old nephrologist which once told me, Ajay, the smartest nephrologist is dumber than the dumbest kidney. So the human body is very, very well made, and half the time we sort of oppose the way it is healing. And to understand what we can do to minimize harm, supporting all organ systems, I think is an important, bigger concept that sometimes we forget. We get so involved in our technical things and treating numbers as opposed to the patient. So how does healing happen in ARDS? Type 2 pneumocytes actually transform to type 1 pneumocytes, reversing the process. Inflammation subsides, so the respiratory membrane becomes that nice functional organ. And how we treat hypoxia is what we are dealing with. Artificial ventilation, minimizing further lung damage. So lung protective strategies of dealing with hypoxia. So let's take the elements at a time. Overcoming the diffusion barrier, higher FiO2. So we always start with turning up the FiO2. It works, but it is the enemy because it itself can lead to toxicity, so I call it a semi-enemy. Higher FiO2 leads to more oxygen in the alveolus, improving the concentration gradient across the inflamed respiratory membrane, allowing at least a little more oxygen to diffuse across into the plasma, and that allows the RBCs to latch onto the oxygen. But it can cause problems. We don't know what the level of toxicity is. We generally sort of used to say that a FiO2 of 0.6 or below is safer, but it is not known what is the level at which the alveolus does not like too much oxygen. Strategy, keep it temporary. If you need to, you have to increase the FiO2 to tide over a crisis, but have a plan. How am I going to get this FiO2 down? How I'm going to recruit, which will go in the further slides, that will allow us to bring the FiO2 down. Second, preventing alveolar collapse. High PEEP, it's a friend with limits, as was very nicely demonstrated yesterday. It prevents collapse during expiration. It reduces atelectrauma because alveoli like this. They don't like this. So the strategy should be that we keep them open and just reduce the degree of expansion and increase the degree of expansion, not make them crash. So reduce atelectrauma. The strategy is minimum PEEP to keep alveoli open and aerated, and of course recruit more. And the advanced tools that were discussed yesterday, transpulmonary pressure using the esophageal balloon, can help you determine what is the optimum PEEP for this particular patient. Preventing alveolar collapse, recruitment of collapsed atlantic alveoli. Again, PEEP serves to recruit, as was discussed yesterday, as we keep on going up on the PEEP. That's a gentle recruitment maneuver. Recruitment maneuvers should be gentle. Again, a lot of discussion happened yesterday about these. They have not been shown to be of benefit, but an individual patient, once in a while, they do work. But again, the key word is gentle. So strategy, I think, is patience. because this is the famous trial that everybody quotes, the ARDSNet first trial of low tidal volume, improving mortality. But the interesting part is the second graph, that actually it took longer for those patients who did benefit to see the benefit. So patience is key. Once you have a reasonable strategy and you feel it is working, you got to stick to it for at least for a little while to prove that it works or does not work. Improving VQ matching, prone positioning has been discussed, and it's proven to be highly effective, especially if started early. And again, all these things I'm repeating, but extreme care has to be there because you can harm the patient. Tubes can get dislodged, lines can get dislodged, anything bad can happen. So it has to be in a very, very stepwise planned fashion. And that video that Dr. Raghu mentioned would be a very useful tool to look at if anybody is considering using this in their ICUs. Inhaled nitric oxide, I'm sure all of you see these fire fountains, whatever they're called. So anybody know what that red thing is just above the main fire fountain?
Some expandable liquid.
Sorry?
Some expandable liquid to break the gas.
Yes, so basically it's a wax seal or an expandable liquid. So if the fire is here, this will take off, not that one. And that is the beauty of inhaled nitric oxide. You inhale it and it goes to the alveoli which are ventilated, where you actually want to improve the perfusion, just like you want this one to go off for a fire here, not that one if a fire is here. So highly effective in the short term, but no demonstrate mortality benefit. But in the short term, I have had a lot of it. I use it unfortunately a lot, but it has a higher cost, and that's why people look for alternatives in terms of prostaglandins. So strategy is individualized care, carefully determined, like there was a lot of discussion yesterday, who may or may not benefit from proning and so on and so forth. And then reset targets. Don't expect 90 and 99. Oxygenation, except SaO2 of 88 to 92%. CO2 washout. Hypercarbia does not kill. It only gives you a headache. And that patient probably has much, much, much bigger problems if he's in severe ARDS than a headache. But what does kill, so losing oxygenation to fix a PaCO2 is a very, very bad bargain. Put a sign up there, nobody touches this ventilator only for CO2. The only way we touch this ventilator is if we want to truly improve oxygenation. But hypercarbia does lead to acidosis, and acidosis can kill. That is why the recommendation to keep the pH 7.2. I personally had a patient whose CO2 stayed above 100 for over 2 weeks, and we were able to control his pH. And then he was a young kid, and we had given him a little too much fluid, so his kidneys were actually working, and they did a fantastic job of adopting. And after 2 weeks, we hardly had to give him bicarb because his kidneys were producing so much bicarb that he was maintaining his own pH over 7.2 with a PaCO2 of above 100. That patient did walk off and lived for 25 years. Last year, I got a text from his father saying Willie passed away. So. Then preventing volute and barotrauma, preventing volute trauma, strategy, low tidal volume. This is an interesting graph that I found somewhere. So as you can see, as the tidal volumes have dropped over the decades, the mortality has dropped significantly. Of course, lots of things have changed, but this is a very interesting graph. There seems to be a strong correlation that over time, as our tidal volumes have fallen, the mortality has decreased too. Preventing barotrauma strategy is to maintain plateau pressures less than 30, as was discussed yesterday. So in summary, ARDS is life-threatening lung condition, myriad causes. Preventative strategies are very important. Treatment is supportive, low tidal volume, optimal PEEP, prevent further lung injury, adjuncts as needed, and patience. ECMO in highly selected, possibly salvageable patients, and that will be discussed tomorrow. Thank you. Happy to take any questions.
So I have a question.
Yes, sir.
Very nice presentation.
Thank you.
If you are doing neuromuscular blockade on these patients, which mode of ventilation would you prefer?
I'll be honest, I have not used for a long time neuromuscular blockade. I've seen the recent trials and I have my doubts about some of these. Once swallowed does not summer make. So I do not use it. I'll let Dr. Raghu take this question.
Yeah, so Deepak, by the time that we are thinking neuromuscular paralysis, typically we would have initiated pressure control ventilation. One of the reasons,
CMV pressure control.
yeah, well, we would have already switched over to pressure control for hypoxemia. At that point, as you can imagine, you only have assist control. There is no way you can put them on spontaneous mode, right? Would be to kill a patient. And one of the reasons why we are a sort of a referral unit, so we see a lot of patients with ARDS from around who come to us. So even in the Oscillate study, one of the things that the Canadians called us and said, every one of your P2F ratio is less than 100. Is it true? So unfortunately, we used to get a lot more. Now it's become less because the other hospitals are also wanting to do sandwich strategies like ECMO. So a lot of our case volumes are based on the referral patterns. So Ajay might be working in a different environment, but for us, and very likely a lot of the patients that we get go to their pulmonary unit.
Yes.
And because we are the ECMO unit, so to speak, they come to the surgical ICU. So it's a sort of a setup that Bob Bartlett built many years ago. That's why we are used to seeing them.
Yeah, ours go to Boston, and second, we are just starting that we will cannulate and within 48 hours transfer to an ECMO unit
Correct.
rather than having our own ECMO program because we don't have the numbers.
Correct, exactly.
So my next question is,
Yes, sir.
whatever we heard, everything if we do early, we get better. So why
Fair.
don't we start ECMO early, within 48 hours? Why
Ah,
do we wait?
good. There is we'll talk about it tomorrow, Deepak. I want to keep the topic.
So how do we decide, you are saying everything early?
No, so there have been studies with the early ECMO too. We'll talk about it tomorrow. As I stop the other gentleman to, like, I don't want this thing to be about
That's fine.
ECMO.
I just wanted the timing, that's all.
Right.
Just go
I have a
ahead.
question for you. Your nitric use, what do you guys start? What do you guys run your nitric at? How many parts per million?
20.
20 parts?
20, though, I personally feel if it doesn't work in 20, it won't work at 40, but some of my partners will come and up it to 40.
And your hospital allows the use of nitric oxide?
Yes, they will complain. They will always call me and say, why don't you use these Flolan and things like that. So,
And what is your protocol or criteria to when you start weaning your nitric at?
when the PF ratio starts to improve to a point that we feel that I be honest, we don't have a protocol. We should. Because again, the numbers don't justify us. I mean, one can argue we should have a protocol if we don't have numbers, but it becomes on a case-by-case basis, and there is a little bit of arbitrariness as to we don't have a specific protocol.
We typically 60%.
70.
70%.
And we run at 10 parts at
Yeah,
area.
FIO to 70%. It's another way for the hospital to make sure the cost is cut.
Okay, yeah. So you start at 10?
For ARDS patients, yeah.
Oh, really? Okay. Wow.
So on the,
Yes, sir.
On the topic of nitrite, I just have a small thing. Like hypotension is a reported adverse effect, and we are already dealing with a lot of adverse effects like hypotension or
What do you say for nitric oxide?
for nitric oxide. Yeah.
Inhaled nitric oxide is in very small amounts. It's only causing pulmonary, so it does not lead to hypotension. You may be referring to a lot of other studies were done in the past where nitric oxide inside the body is a.
That is if we are injecting it. So I just had this part where we are
No, so the systemic effect
systemic
is close
effect
to zero.
is close to zero.
Yeah.
After this.
Any other questions?
Okay, thank you, Ajay.